Hello, good morning. I am Dr. Shiv Mantri, faculty at Karni Dental College, Jabalpur. Today I will show you the management of a patient with the chief or primary complaint of painful lower left molar tooth and secondary complaints of food lodgement, caries and stains in the other teeth. Seven is having pet fissure caries. 6 is badly decayed. Then you have the 6 is caries, buccal caries. This is all pit and fissure caries. All teeth are caries, having pit and fissure caries. Upper teeth, only one upper tooth is caries, that is upper left axillary first molar, having the foot lodgement interdentally between premolar and molar, having a proximal caries lesion also, along with breakage, extensive caries lesion, including dentinal caries lesion, and then so we have the lower teeth where almost all molars they are caries, having pit and fissure caries, and then the patient has some stains and moderate plaque buildup. On upper left central incisor, and the right incisor is prepared for, I think, for veneer, because both palatally there is no preparation as such. This was having either a veneer prep, which is a dislodge. I think there is a veneer, right? There is a plaque window. So what we need to do is, first is we check tenderness. दर्द होता है इसमें दर्द होता है, ऐसा होता है, हाँ. This tooth is tender when we are percussing with the handle of the needle, but it is not tender when I am percussing with my finger. This tooth also I need to check. इसमें दर्द होता है, इसमें होता है दर्द, होता है थोड़ा, होता है. This tooth is also tender, but so she needs restorations. बोला बेटा, she needs restoration, molars, and then root canal treatment of these three teeth. I think upper molar also will go for the root canal treatment, pulpectomy and root canal treatment. We'll take radiograph of these teeth. So some periapical lesion, and where this tooth is having a periapical lesion in the anterior. This is left. This is right central incisor is having some periapical lesion, little bit widening of the rounded ligament space. This particular tooth is having. So cold test is negative in this tooth, whereas cold test is positive in this tooth. Okay. So I think rubber dam can be applied on this tooth. Before that, we need to remove some calculus, deposit interdentally little bit, and then on this tooth, so that we get secure clamp placement. Putting the landmarks, and then injecting. थोड़ा लगेगा बेटा, थोड़ा लगेगा. Right. Aspirating and then injecting a little bit slowly. You have to. This is a disposable syringe with a disposable needle, and aspirate till 2.5 ml. But we don't require to give whole of the volume. We are supposed to inject around 1.8 ml, which is available in standardized cartridge. Here we are not using standardized cartridge, we are using a disposable syringe and needles. It is marked, so we will inject till just short of 0.5 ml. So it can be secured firmly and the clamp is stable, but we have not tied the clamp, so we need to tie the clamp. So this is just checking the clamp. Checking the interdental, whether it is clear, floss will go inside, and tightness of the contacts. So the floss can pass easily. Little bit tight contact is there, but the floss has not shred. So we have little bit tightness of the contact. And so we have cleaned up the tooth. We have cleared the D junction. We just have to remove the unsupported. Just have to remove unsupported enamel a little bit so that we get a stable reference point. This may reduce your provisional working length when you are done. So we have. Now we lost the anatomical landmarks, the classical access preparation. So we are not going to do endo build-up because we will waste lot of material. So we cannot follow the laws here, law of symmetry and all. So we have to go till the center, the mesial third of the crown approximately, and then penetrate. So we have entered the pulp chamber. You can see the bleeding coming out. Canal is bleeding. So this is the orifice, distal canal. I am in pain a little bit. नीचे बक्कल लीजिए लेंगे 10 number K5 distal orifice mesobuccal थोड़ा सा लगेगा बेटा. Mesobuccal is little bit tight. Mesolingual. Canal is supposed to be curved. Mesolingual canal is relatively straight as compared to mesobuccal canal. Mesolingual is usually, though it is a tight canal, narrowest canal, but still we can get it. So 10 number K file should be loose. So we establish a glide path for success. Calcification, loose calcified mass, this has come out. You can see this is a, in the distal canal itself. That has to smoothen the coronal part and clear the orifice, make it straight line. A little bit on the mesolingual side. I am not going to insert much, just to remove. Mesobuccal. Little bit just to free up the coronal interferences. So one must ensure the coronal interferences are removed before insertion of rotary files, especially the smaller files. Otherwise the files are very easy to break, and we ensure 20 number file and K file go easily till 39. It should be, if it is not going, then little bit manipulated. Motion strokes are quarter turn full, quarter turn full. And the amplitude of pulling is 1 to 2 mm, not more than that. 1 mm, max is 1 mm. Is not going till apex. So again do it little bit, either watch winding motion or just a simple filing motion, that is inside out. This may extrude debris out, then you have to ensure it. Mesolingual. Mesolingual is a relatively straight canal as compared to mesobuccal canal. So it is easy, but mesobuccal you have to be careful before inserting any rotary file, because it is more prone for incidence of fracture. So our initial hand cleaning is clear. Open. Now we start with rotary file. Okay. Visible? This is 54% we have inserted. Now I am inserting in the mesolingual canal till apex. the distal canal. Your file must be rotating before insertion in the canal, and it should be coated with either some lubricant or especially the RC prep. The small inside out strokes and some brushing action on the canal wall lead to two canals in the distal. So I am using a lingual distal lingual canal now. Little bit tighter canal, so don't never force your instrument. It should be gently inserted and should not be forced. No application of force on the night eye rotary files, just gentle, otherwise your file will break. You can see the debris coming out. Now you can see the canal, distal canal is confluence. Both the canals, they are confluence in the coronal third now. And you just have to verify again the distal canal, whether there are two canals or it is a dumbbell shaped canal. I think it is a dumbbell shaped canal. Yeah, they are confluence and the coronal third was so you have to prepare dumbbell shaped canal like two canals. The connecting part of the dumbbell shape can be cleaned using irrigation, either by using ultrasonic or sonic irrigation. You can use I am using 4%. You should be very careful in mesiobuccal canal because it is curved. Never force it. Use little bit lubricant. That is AGTA anti-latex. And I couldn't do it. I could get it latex. I am using it in mesiolingual canal now, which is relatively straight canal. Of course, it is tighter and narrower than the mesiobuccal canal, but the course of canal is straight. In between, we can clean it. You are supposed to use a sponge for cleaning. consistency of the canal using a 10 pipe. Now we are going to close it. We are finished up. पेट्रोल देता है बंद कर दो. सीधा टेम्परेरी कर देंगे.